Common normal variations. Introduction. There exists an extremely wide range of normal. Therefore, we should know when to treat and when to not treat our patient. Common normal variations that could be found in children is particularly common in lower limb, such as flat feet, knock knees, bow legs, toeing out, and toeing in. These are extremely common in young children, however, it becomes less common in adolescents. There are two big groups of normal variations in children. First is joint laxity or hypermobility, and the second is twisting or torsional deformity of the growing long bones. Variations caused by joint laxity. Joint laxity. It is extremely common in infancy, however it becomes relatively uncommon in adults. It's probably due to inherited variation. There are two common clinical variations, flat feet and knock knees. Both are aggravated by obesity. For the flexible flat feet, at the age of 1 year, all joints are normally hypermobile. It is usually generalized. We could also find flat hand, and the feet only become flat with white bearing. The mild and moderate degree need no treatment, only reassurance for the parents. For severe form, simply prevent further stretching by wearing boots with sponge rubber arch support or scaphoid pad. Weight the ligaments become less lax with age. It must be differentiated from rigid valgus feet and accessory tarsal scaphoid. This figure shows flexible flat feet in a 1.5-year-old child. The second figure shows both flexible flat feet and flexible hand in a 10-year-old boy with persistent generalized joint laxity. This figure shows a boot that used only for preschool children with severe flexible flat feet. The last figure shows the hypermobility of the joints in the upper limb. Knock knees. Simply another manifestation of generalized joint laxity. Lax medial collateral ligaments is most noticeable when standing. It is corrected spontaneously in more than 90% of children. The aim of treatment should be simply to prevent further stretching with avoiding W position. Must be differentiated from genufalgum because of epiphyseal plate disturbance due to congenital abnormalities, metabolic condition, or injury. This is the figure shows the knock knees. This is the figures that show the W or a television position of sitting. This figure shows knock knees in a 12-year-old girl with persistent generalized joint laxity. This figure shows a corrective splint that was worn at night for 9 months to influence the epiphyseal plate growth at the knees. Variations caused by torsional deformity of growing long bones. Torsional deformity of growing long bones. It usually repeated twisting or torsional forces by an alteration of the normal growth pattern. It usually twisted in its long axis. It could either be internal or external torsional deformity. It may be due to prenatal intrauterine position or certain habitual sleeping and sitting positions. Toeing out. External femoral torsion or lateral femoral torsion. It is common in young children, nearly always caused by external femoral torsion. They sleep face down with the femoral externally rotated, which may add external tibial torsion. However, the prognosis is good. Other type of toeing out is external tibial torsion or lateral tibial torsion. It's rarely alone. It may aggravate from external femoral torsion or may be due to compensate internal femoral torsion. It could also develop secondary to muscle imbalance such as spina bifida, CP, and polio. External rotation of entire low limb could also be due to congenital dislocation or slipped upper femoral epiphysis. Toeing in. Internal femoral torsion or medial femoral torsion. It is due to the habit of position W that could also be called as acquired deformity. When the knee rotated internally, the knees turn in to about 90 degrees. When the knee rotated externally, the knees can be brought only slightly beyond the neutral position. The aim of treatment is to simply prevent further internal torsion. To stop habit of sitting W, instead tailor like position such as Brasilia. Corrective devices can also be used. This figure shows the W or television position of sitting that has gradually produced an acquired internal femoral torsion and external tibial torsion in this 9-year-old girl. This figure shows the tailor or cross-leg position in which an external torsional force is applied to the femur, helps to correct the internal femoral torsion. This specially designed corrective splint is used at night to apply a mild external torsion force to the growing femur and thereby correct internal femoral torsion. Other type of toeing in is internal tibial torsion. It is most common cause of toeing in young children. It is normally corrected spontaneously with subsequent growth. It is due to habitual sleeping position or sleeping on the knees with the feet turned in, and could also due to habitual sitting position or sitting on top of intern feet. The aim of treatment is to prevent internal torsional forces, such as training the child to avoid this harmful position of sleeping and sitting. If severe, in child older than 2 years, treatment is justifiable. Hold the feet in externally rotation by night splint. Differential diagnosis in this condition is metatarsus varus and club feet. This figure shows internal tibial torsion. When the knee is facing forward, the foot is turned inward. This is a Dennis Brown night splint with their feet externally rotated, applies a mild external torsional force to the growing tibiae, and gradually corrects internal tibial torsion over a period of 4 to 8 months. This sleeping position with the feet turned in and underneath the infant applies further torsional force to the tibiae and not only prevents spontaneous correction of the internal tibial torsion, but also aggravates it. This sitting position with the feet turned in and underneath the girl applies further torsional force to the tibiae, preventing spontaneous correction of the internal tibial torsion and perhaps actually aggravating it. Other type of towing in is bow legs or genupharum. The most common cause is due to internal torsion and varus of the tibia with external torsion of the femur. It is not simply the opposite of knocked knees, frequently present at birth but may be aggravated by habitual harmful position of sleeping and sitting. In persistent genupharum in children older than 2 years, we should use the night splint. Other differential diagnoses that we should consider is rickets, tibia fara, and epiphyseal plate injuries. This figure shows a bow leg genupharum caused by a combination of internal torsion and varus of the tibia along with external torsion of femur in a 2-year-old girl. This figure shows a specially designed corrective splint for children older than 2 years of age is used at night to influence epiphyseal plate growth and thereby correct the genupharum. Normal variations in adults. There are residual flat feet, knock knees, and bow legs. It may produce symptoms because of premature degeneration of associated joints. It is a normal aging process in the musculoskeletal system. It could gradually decrease in muscle strength, gradual decrease in joint motion, or chondromalacia, gradual decrease of water content in intervertebral disc, osteoporosis. This figure shows a generalized osteoporosis seen in the pelvis and femora of a 76-year-old woman. This figure shows a dorsal kyphosis or round back associated with osteoporosis of the spine in a 61-year-old man. That's all the presentation. Thank you for listening.